Again, I'm gonna do my absolute best here to see the deeper anatomy inside of your antebrachium. And the first big muscle you're gonna see here is called flexor digitorum superficialis. So, in today's video, we're talking all about carpal tunnel syndrome and the median nerve. But to do it properly, we can't just speak about the wrist. We're gonna need to take a look at the neck as well as a whole bunch of arm anatomy. So there's a lot to do, but it's gonna be fun. So let's do this. To start off with, we need to understand that there's actually a difference between the carpal tunnel and carpal tunnel syndrome. The carpal tunnel, it's a real place. It's located here in your wrist, and there's many different structures running through it. While carpal tunnel syndrome is when pressure is building inside of that tunnel, affecting the nerve inside and then muscles downstream of it. So, in order to really understand this, let's go ahead and take a look at the bony boundaries of that carpal tunnel. And luckily for us, Jeffrey here is willing to lend a hand. You're looking at the palmar side of the wrist on a left hand, and you're gonna notice there are a bunch of bones right here. These are called the carpal bones or the wrist bones. And there are 8 of them in total, but we're really only gonna focus on 4 of them. The first 2 are gonna be located here on the ulnar side, and you'll notice there's some metal attached to a bone here. This is called the pisiform bone. Then, right next to it, I'm gonna slide my finger under there, and that's gonna allow you to see this projection coming out of there. This bone is the hamate bone. And that little projection that's coming off of it right there is called the hook of the hamate. So both of those are gonna form the ulnar side of the carpal tunnel. So then if we jump over to the radial side, that's this bone here, we have another bone that has some metal attached to it. This is called the trapezium. And then right next to it, we have the scaphoid. I'm doing my best to highlight these, kind of difficult, but the scaphoid and the trapezium are going to form that radial border of that carpal tunnel. So if you think of the carpal tunnel almost like maybe like a room or a building of some sort, you're gonna have walls. Well, that means you also need to have a floor and a ceiling or a roof of some kind. Well, the floor is going to be the rest of the carpal bones. That means the ceiling, which is gonna bridge the gap. If I kind of do my best to lift this up, you can see that that hook of the hamate and the pisiform would kind of be at the same level as the trapezium, and there's going to be a dense piece of connective tissue that's gonna bridge that gap and allow for structures such as the median nerve and several tendons to run right through it. And we will get to see that dense piece of connective tissue on the cadaver coming up. But the median nerve that goes through the carpal tunnel actually has a long journey before it gets to the wrist, and it starts all the way up in the neck. So let's go ahead, jump over to the cadaver and check it out. You're looking at the right side of the neck from a lateral or side view with the arm removed. And you can see that we've cut the clavicle here, or what you may call the collarbone. And we've also cut this muscle here called the sternocleidomastoid. And we did that so we could take it and reflect it back to reveal this deeper neck anatomy. And you may also notice, if you have an eagle eye, that there is some string in here. And to the best of my knowledge, you don't come with string. This is where the embalmers actually went in to deliver the embalming fluid to the body. So what they would do is pump it into the carotid artery, and then the embalming fluid and preservatives would get pushed throughout the entire arterial network in the cardiovascular system. So then they just stitched it closed with this string. But what we really want to focus on is all of this anatomy right here. And so this little dangly part right here is actually some nerves, which is kind of interesting to see. But what we really want to focus on is this right here. This is the brachial plexus. This is the beginnings of 17 different nerves. And those 17 nerves go, well, they cover a lot of real estate. They go to your entire upper limb. They go to your pecs. They go to the muscles of the back. They even go to your diaphragm. So this is a busy area, this brachial plexus. And there's a bunch of sensory and motor neurons traveling back and forth. So that means it brings in sensation as well as delivers motor information. But not only is the brachial plexus in this area, we also see a gigantic blood vessel here called the subclavian artery. And this subclavian artery is going to be delivering oxygenated blood to your upper limb. But what's interesting is what they're traveling between. So if we look right here at that plexus in the artery, you're gonna notice with my probe here, touching a muscle called anterior scalene. And then if I grab it, push it back this way, you see there is another muscle right here called middle scalene. Again, we have those nerves coming off of the brachial plexus. So that means that the brachial plexus and the subclavian artery are traveling between two muscles, and this could create a potential problem called brachial plexus impingement or brachial plexus injury. How likely is it that you're experiencing that and not carpal tunnel? Well, that would depend on your clinician to find out, right? Because the brachial plexus will eventually turn into the median nerve. But here's the thing. If you're wondering if you really have carpal tunnel or if you have brachial plexus injury, you do some tests, because if you only have carpal tunnel, then where would you expect to see symptoms? Only where the median nerve goes to, correct? But with the brachial plexus, since there's 17 nerves, if you have an impingement or like based on some kind of trauma, infection, maybe you have just terrible posture, you would expect to see farther reaching symptoms. So again, that's why it comes to your clinician to help figure that out. But what I want to do is I want to see where the median nerve comes off of here. In order to do that, we're going to need to take a look at the cadaver's arm. So let's go ahead and do that. You're looking at the right upper limb of the cadaver we were just looking at. So you can see, for instance, that clavicle that was cut. You can see the continuation of that. You can see the scapula, several scapular muscles. But what we really want to focus on is going to be this area right here. And I'm going to do my absolute best for you to be able to see this. This muscle is actually pectoralis major that we've cut, so we can reflect that back. And you're seeing basically the inside of your armpit. And you can see the continuation of that blood vessel we just saw, the subclavian artery. This is the axillary artery, and that will then continue down into the brachium and become the brachial artery. But what we really want to focus on is this portion right here. And I know it probably doesn't look like much, but there are three kind of, well, they're not really tubes, they're more like cord-like structures embedded in connective tissue going right by that artery. This is going to be the continuation of that brachial plexus, and specifically what I'm putting my probe around right now, I'm going to do my absolute best, kind of change angles so you can try and see this. This right here is the median nerve, and that median nerve is going to be running alongside this artery. So as the axillary artery continues to become the brachial artery, the median nerve is running along with it, and it's going to be going between the biceps brachii, which is what I'm holding here, and then the brachialis. And they're just going to run down until they get to what sometimes people will call like your elbow pit, but it's really the cubital fossa or cubital space. And that is this area right here. And this is where the median nerve is now going to start to go through this muscle right there. I'm gonna do my absolute best for you to see this, trace it around. This is the pronator teres muscle. And what you really can't tell from looking at the cadaver right here is that there are two heads to this muscle. So you can almost think of it like they're kind of stacked on top of each other. And what's happening is the median nerve goes between those two heads of the muscle. And that can create a possible problem. It's called pronator teres syndrome, because if the muscle becomes tight and compressed, it can start, well, compressing the median nerve, and that can create paresthesia, which is essentially like pins and needles, or numbness, weakness, tingling, that type of thing, going down the arm. And it can even create some weakness in the action called pronation. So if you stick your hand out in front of you with your palm facing up, this is called supination. And then if you just rotate your hand like so, that's pronation. And pronator teres is one of two muscles that performs that action. We'll see the second one here in a second. So kind of interesting to see that the median nerve has multiple places that it could actually experience a problem. We've seen the neck, now we've seen pronator teres, and we're about to get to the carpal tunnel. So one other thing I do want to show you is that the median nerve is then going to keep traveling down, and we're going to see it in a second, but we'll have to look at a different cadaver dissection. And instead, what I really want to focus on is going to be right here in the wrist. And you're going to notice that I have blurred the hand or those fingertips. And that's because people just tend to be very uncomfortable with fingertips, and I get it. If I hand someone a brain or a heart or lungs, those are kind of abstract. It's not something you deal with on a day-to-day basis, but we see our fingertips. So whenever people see those, it makes them uncomfortable. So I'm just gonna keep those blurred out for you. But again, let's take a look at the wrist here, especially if I turn it to the side. Especially, do you see this gap that's forming? Hopefully that's not too blurry. There's this muscle right here. This is called the palmaris longus muscle, and you'll see that all of a sudden it's just running into a piece of connective tissue that's keeping it down. This piece of connective tissue that is running around, and it even goes onto the other side, right? You can see all right here. This is the retinaculum, but on this side we call it the extensor retinaculum. And on this side, we call it the flexor retinaculum. And what it's doing is it's binding the tendons down of the forearm as they go into the wrist. So if you think about it, as you're moving your wrist, you don't want the tendons that are sometimes, some of them are going straight to your fingertips. If you moved your wrist, they would just go like straight, that doesn't make sense. You don't want to be like this winged bat creature with skin flaps coming up. So the retinaculum binds those tendons down. Now, what's interesting to us is what's part of that flexor retinaculum, if we go deeper down, is what's called the transverse carpal ligament. And this is that ceiling to our carpal tunnel that we talked about, that was bridging the gap from the scaphoid, the trapezium, all the way over to the hamate and that pisiform. So this is going to be important. So just keep this in your mind as we go ahead and look at this other cadaver dissection. So you're looking at a left arm that has been cut about not quite mid-brachium, just a little bit distal to that, but that allows us to see the elbow and then a bunch of that forearm anatomy and into the hand. And once again, you're going to see that I'm blurring those fingertips just to make everybody super comfortable, or as comfortable as you can be. But we're going to be focusing on this area here called the anterior antebrachium, also sometimes called the flexors. And there are 8 muscles located in that anterior antebrachial compartment, and we're going to see pretty much all of them right about now. So we're going to go ahead and just start kind of piecing it out. So the first one I want to look at is this one here called the flexor carpi ulnaris. Now, flexor carpi ulnaris's name sounds kind of intimidating, but if you know how to break it down, it's really not that bad. It's just saying flexing the wrist on the ulnar side. That's basically what the name means. But I want to try and, oh, by the way, this thing that's kind of hanging down here is part of the ulnar nerve, which is just below it. So if I kind of expose it that way, so you're just seeing a little bit of an offshoot of that ulnar nerve. But right deep to it is also the ulnar artery. So I'll do my best to kind of throw this. This is going to be a difficult one to hold around just by the way we've done it, but we have the ulnar artery and the ulnar nerve that are just below this muscle here, that flexor carpi ulnaris. So it's just being protected by it. Now, I have to make sure you understand that the ulnar nerve was actually part of the brachial plexus, just like the median nerve. It just happens to take a different path, and that means it doesn't go through the carpal tunnel, which we're going to be looking at here in a second. Instead, it goes on top of it. And then the artery is just running alongside with it. Then we also have this muscle right here. It's a really long one. I mentioned this earlier. This is called palmaris longus. So I'm going to do my best for you to see this. Palmaris longus is a very interesting muscle that we're going to have to do a video all about it, because not every one of you have a palmaris longus, or at least you might have one, or you might be missing both, or you might have both. And so it's an interesting muscle that we'll have to discuss at a later time. But we cut palmaris longus here. And then we also cut on this side another muscle called flexor carpi radialis. And it's kind of similar to flexor carpi ulnaris. It's just flexing the wrist on that radial side. But when we cut those, it allows us, again, I'm gonna do my absolute best here, to see the deeper anatomy inside of your antebrachium. And the first big muscle you're gonna see here is called flexor digitorum superficialis. So see if we can see just how massive this muscle is. It is a big, big muscle. I'll try to get a better view of that here. So if you break down the name flexor digitorum superficialis, it just flexes your digits and it's superficial, except it flexes digits 2 through 5. So they're numbered and their thumb is number 1. So by going to 2 through 5, it omits the thumb, but we'll see someone else goes there. So flexor digitorum superficialis is the first muscle we know of or see that goes through the carpal tunnel. So 4 of its tendons are going to go through the carpal tunnel, and you can see we've cut it right here. So this is where you're entering into that carpal tunnel type area. But when we cut it, that allows us to see deeper down. And first you're going to see all this white. If I can kind of push that to the side, you see all this white stuff? That is the tendon, or part of the tendinous portion of flexor digitorum profundus, right? So we had flexor digitorum superficialis, now we have flexor digitorum profundus, and profundus just means deep. In fact, it goes to the exact same place, more or less, there's a little bit of difference, but it's not that big of a deal, as superficialis, digits 2 through 5. And it too goes through the carpal tunnel. So that's 4 more tendons going through the carpal tunnel. But there's another one right here. Again, do my absolute best for you to see that. Right here, this muscle is called flexor pollicis longus. And flexor pollicis longus, pollicis means thumb. So it's going to the thumb to flex it. So we now have the ability to flex all of our digits. It too goes through the carpal tunnel. So that's 1 more tendon. So we had 4 plus 1. That gives us 9 total tendons plus, are you ready? This right here is the median nerve. So I'll do my absolute best. Again, I apologize. This is a little difficult to do, but this right here is the median nerve. And the median nerve is traveling between flexor digitorum profundus and flexor digitorum superficialis. And then it goes through that carpal tunnel. So the carpal tunnel is a busy area. There's 9 tendons plus this nerve all going through this. Just picture that, right? Like as you're flexing all and moving your digits, they're all just sliding back and forth against the median nerve, and it's just hanging out, you know, feeling kind of compacted, I guess you could say. But typically that's not a big deal. It's only when you get inflammation and that pressure starts to really push on the median nerve that you get a problem, and that's called carpal tunnel syndrome. But there's a couple other things I want to show you here. Really deep in there. See if I can do this. Really deep in there. I don't know if you can see this all that well. I apologize again. Right here is another muscle called pronator quadratus. And I mentioned that I would show you pronator quadratus later on. And so this one is a 4-sided muscle. So we saw pronator teres earlier. Quadratus is basically, it's not quite the floor of your carpal tunnel because it's right before the carpal tunnel, but it's kind of sort of ish. And it's just this 4-sided muscle that also helps you with pronation. Just flip your hand over. So one thing I want to talk about is that the median nerve starts splitting like crazy. And in fact, it's going to split before we actually see it here and turn into another nerve that's going to go deeper. And then it's going to split a couple more times here in and around the wrist and in the hand and become about 3 different nerves. It's going to start going to the muscles of the thumb, the muscles of the digits, as well as the skin of the hand and digits. Now, the other thing we have to take note of is that the median nerve, when it goes to flexor digitorum profundus here, it only goes to 1/2 of it. The ulnar nerve takes the other half of it. And this is actually going to be important, especially in the cutaneous, really more so with the cutaneous field that we'll see in a second. But it's just kind of interesting to see that the median nerve is actually in charge of the 8 muscles that are in here, which we've seen most of those. Of the 8 muscles, the median nerve is in charge of 6.5 of them. The ulnar nerve is in charge of 1.5. So kind of interesting how that plays out. But how do we know if we have carpal tunnel syndrome? Let's figure that out. So again, as that median nerve goes through the carpal tunnel, I want you to picture right here, deep to this flexor retinaculum, we have that transverse carpal ligament. You can picture that median nerve just in this busy area getting compressed. Let's say some kind of inflammation occurs here, and we'll discuss why in a second. Well, what's going to happen is you're going to start experiencing symptoms that are then going to go downstream. And the thing to understand is the median nerve, in terms of its cutaneous field, which is basically just the sensation on the hand, is only really going to go to these 3 digits. Well, also half of your ring finger. Why this is important is because if you're saying you have, or thinking you have carpal tunnel, or say like you're telling your doctor that you have carpal tunnel, they're going to be looking to see that it's just these 3 digits and half of the ring finger. Because if you're also feeling it in the pinky, well, that's actually the ulnar nerve's job. So if we go back here, again, I apologize, this isn't the most elegant way to do this, but that's the pinky is taken care of by the ulnar nerve in terms of its cutaneous field, so the sensation on the skin. So if you're feeling it in the ulnar nerve, well, that's not carpal tunnel. That means you have something else happening that's encompassing the entire hand. So there are a couple tests that you can actually do to try and figure out if it's specifically carpal tunnel, or maybe it's pronator teres syndrome or something else. And the first one is called Tunnel's sign. Tunnel's sign is basically just tapping. right? So I mean, think about it. If there's a bunch of compression, there's a bunch of fluid inflammation, that type of thing, just literally hitting it can create a jump sign. You can get some pinging, some paresthesia, that numbness, tingling, all that kind of stuff that can just start going down. But again, it should just be going to those 3 digits because you're banging on the carpal tunnel. Now there's another one called Phelan's sign or Phelan's test. And what you would do is put your hands like this and then compress them as far as you can go. And what you're doing is, you can see, you're compressing that carpal tunnel. And you're gonna hold this for about a minute. And pretty much everybody's gonna go numb after a minute. But if you have carpal tunnel syndrome, you are gonna start experiencing weakness, tingling, all those types of sensations earlier than a minute. And the faster it happens, the more severe your carpal tunnel syndrome, if that makes sense. Now there's other tests you can do. One of my favorites is called like a pinch grip test. You can like put a piece of paper in there and try to pinch and see if there's any muscle weakness in that area and try to steal the paper. But the thing to understand is there's no real like slam dunk test for carpal tunnel syndrome. So what your physician is going to pretty much do is start giving you other ways to try and remedy it before going to the surgical route. Because I mean, ice, corticosteroids, massage therapy, splinting even, just kind of put a splint on the wrist, try to keep it straight. All of those are good treatments to at least try and fix it before you have to go the surgical route. But if you have to go the surgical route, what they're going to do is they are going to make an incision either in the hand or on top of that carpal tunnel or in the wrist. And what they'll do is they'll cut it with a scalpel. They will then go in there and with a blade, they will literally cut that ceiling. They'll cut the transverse carpal ligament. And what that will do is free up the median nerve so then the pressure can dissipate. But that's the thing. What's causing the pressure? What are the risk factors? The cause of carpal tunnel syndrome is actually mysterious a lot of the time. We don't know, it just kind of shows up. And that can be super frustrating because then it's like, how do you properly treat it? Interestingly, it also shows up in females far more than males. And that likely has to do with, say, like hormonal influences and fluid retention. So that would make a lot of sense. But sometimes we just really don't know. It literally just comes out of nowhere. But other times it's things like diabetes or rheumatoid arthritis or pregnancy, or those are all going to increase the risk of you getting carpal tunnel syndrome. But by far and large, it's the repetitiveness and also forceful exertions that we tend to see the most. So let's say like you're picking up something heavy, you're lifting and you're extending your wrist like this, that's putting a lot of pressure on that flexor retinaculum, the transverse carpal ligament, and you can actually get some agitation that could result in some inflammation. So it makes a lot of sense. But that's the thing, since it can be kind of mysterious as to what's causing it, that's why you want to be really careful with your remedies and your treatments. You don't want to just jump to the surgical bandwagon before you start doing some ice, splinting, and all the stuff that we discussed earlier. Thanks for watching, everybody. I hope you enjoyed this one. Be sure to like, comment, subscribe, hit the notification bell so you can be the first to see all of our videos as they come out. But again, thanks for hanging out with me, and I will see you in the next video.